several years ago as a medical student, heard about the FMEC, heard all about the connections of innovators and educators that were coming. And I just remember being struck by how family medicine seems to be the place where a lot of innovations are happening in health systems. So I was really drawn to it as a specialty for that reason. So hats off to you all. So first things first, Luis and I, Luis is going to introduce himself in a moment. We're really excited to talk with you all about how to advance health equity in Wisconsin called clinic-based community organizing. My name is Brian Park. I'm faculty at the Oregon Health and Science University in Portland, Oregon, the Department of Family Medicine and the School of Public Health there. But these days, I feel like I'm more often known as the happiest person at OHST. And the reason for that is that about 4 months ago, I became a parent for the very first time. It's my son Miles, and that was his Halloween costume there. And there's nothing like becoming a parent to really understand what's just most important in life. And after Miles was born, I had an opportunity to just reflect on what did I want out of my professional career, my vocation. And really my mission statement in my life is really how do we make healthcare more relational and equitable for our teams, our patients, and our communities. I feel like it's a huge privilege. All the hats that I wear at OHST is for that mission, so I feel very lucky. So I just want to talk to you about one component of the work that I have an opportunity to do. So the clinical practice that I'm a part of, that both Luis and I trained at, is the Richmond Clinic. We're a community health center in southeast Portland. And we were designed as a community health center in the early 2000s to serve the urban underserved in Portland, Oregon. And we serve about 16,000 patients annually. 48% of our patients are insured under Medicaid, and just over 80% of our patients identify as having median household incomes below 200% of federal poverty level. I always like to joke that I grew up at Richmond Clinic. I grew up professionally at Richmond Clinic. I did my internship, my residency. I got my first faculty gig, and I'm still there today. And a lot of my steep learning curve there was around more sophisticated thinking around the social determinants of health and health equity. And I learned 3 really important lessons there that really contributed to the work that Luis and I are going to share with you. So I just want to share with you those 3 lessons here first. But before I do, I just want to level set on some terms that I think are really important before we start. We're going to go over these definitions quite a bit. Earlier this year in the Health Affairs blog, Brian Castrucci, the CEO of the Dave Lamont Foundation, said that there's social needs and there's the social determinants of health. Social needs are midstream. Those are things like housing, food insecurity, access to education, et cetera, et cetera. And upstream to that are what he called the social determinants of health, which these days means everything and means nothing. So he was saying that those are really how access and opportunities to social needs happen. So he wrote, social needs are the downstream manifestations of the impact of the social determinants of health on the community. So improvements in our nation's health can be achieved only when we have the commitment to move even further upstream to change the social determinants that make people sick. And my favorite sentence in any peer-reviewed article this year, words matter. Yes, it does. All right, so lesson number 1 for me. Addressing social determinants of health means addressing power. So when I started my residency training at Richmond Clinic, this was how I viewed the world. I viewed the world as an onion. That biology and genetics played an important role in health, but even more so than that, behaviors and lifestyle, things like diet and exercise. But even more so than that, social needs. Housing, education, food. I know what you're thinking. Thank you, Captain Obvious, right? I mean, when I started med school, this was like cutting edge stuff. Now everyone knows this, right? Something happened during my second year of residency at Richmond Clinic where we were doing a population health project. I noticed that 2 neighboring neighborhoods in our catchment area, 6 years of life expectancy separated those neighborhoods. 6 years of life. And to me, I could not wrap my mind around that being determined by biology or genetics, by behaviors or lifestyles, or even social needs. To me, those were questions, 6 years of life separated by 1 city block, of the social determinants of health, community conditions, things like racism, sexism, ageism, classism, things that distribute inequitably access to social needs, behavior, and lifestyle. That to me is a question about power. Who in our society has access to power and who doesn't? Or as Martin Luther King Jr. said, power is the ability to achieve purpose. Or as one of my medical idols, Tony Eichmann, said, powerlessness is making us sick. Or as Marjorie Gibbons and David Kindig, who coined the term population health at the University of Wisconsin, said, addressing patient social needs alone will not support our nation's efforts to reach our health potential. It is time to address power. So advancing equity requires attention to power as a determinant and building power as a process, as an intervention. So that led me to lesson number 2, which was that addressing power means engaging patients in an entirely new way. So let me explain what I mean. A group here at the East Coast called Rethink Health, started by the Ripple Foundation, did an environmental national scan of which organizations, which health systems were performing highly in addressing health equity and which weren't. What separated the high performers from the rest? And they found that one of those ways was how we engage residents and patients as leaders in the health system. So on the left side, the resident awareness and participation, that's how we traditionally engage patients in communities, right? We say, we have a diabetes group, come if you'd like. In the middle there, getting feedback and input from residents and patients. That's what we started doing with patient advisory councils, community advisory councils. Give us feedback about the care you're receiving. We might incorporate it, we might not. What the high performers and the bright spots seem to be doing are actively engaging residents, communities, and patients to be civic leaders, developing leadership potential, having them actually have a say at the table of the decision. So if I intersect those two lessons, I ask myself, how do we create power to address the social determinants of health and equity? So all I've done here is the x-axis is that same slide you just saw, patient leadership on the far right, and then the social determinants of health and equity upstream on the y-axis. So let's use Richmond Clinic, where I work, as a case study about this. I'm really proud of the work that we do in this clinic. So patient awareness and participation. The biological determinants, we use evidence-based practices. We have a robust team to do robust diabetes outreach. Going upstream with behavioral factors, we have a behavioral health provider for every 4 to 5 providers in our clinic. So they're able to provide robust counseling around lifestyle, diet, exercise. And we have a really innovative social needs program where we're able to oversee CSAs, fresh fruits and vegetables through VeggieRx programs. Patient feedback, and we have a great patient advisory council. And we also do a regular community health needs assessment as part of our ACO as well. As I looked at what we did as a clinic, though, I saw an immense level of opportunity. That we weren't really engaged in patient-resident leadership, and that we weren't really engaged in actually doing something about the social determinants of health and equity. So Luis and I have devoted our last 5 to 6 years of our career, our lives, of looking at that space. How do we build patient capacity to address the social determinants of health and equity? Does that make sense? Leads me to lesson number 3, and this is unlearning things that I've learned over the last 10 years of my medical education, which is that addressing power to patient leadership does not happen in the exam. One of my idols, Jack Geiger, said, if, however, structural competency is taken to imply that health professionals can change politically determined social determinants of health in the course of a clinical encounter, I disagree, and so do I. So, Luis and I, we put together a program in partnership with an academic health center, the community health center that we worked at, and a community-based organizations. And there were 5 core assumptions that we developed this program. So number 1, health is larger than healthcare, if we can agree. Health doesn't happen in exam rooms, but in communities where people live, work, and play. It's the World Health Organization. And we cannot treat only individuals, we must also treat communities. This is a population health approach to health. Usually when we give this talk, people are nodding along to this point, and then the next 2 points are where I lose some people. So if I do, let me know. But if I follow this through line here, then we cannot diagnose only illnesses. We must also diagnose ill and not just structures in our community. And if that's true, we cannot prescribe only medications. We must also prescribe new practices, policies, and systems that redistribute power. So what we're trying to do is really bring together 3 different sectors of society that don't always align. Bring together healthcare, patients, and community organizations. And just starting the conversation about how can we co-create what health looks like in our country today. So we're really trying to look at that a little out there. Because usually healthcare is reorganizing healthcare systems Patients and community organizations are working on structures. So what are the opportunities that come alive to us when that overlaps? It's interesting. For as long as Luis and I have been doing this, the years that we've been doing this, when we ask patients what they need for help, not one person has said, please reorganize HMOs. Not one person has said, please restructure primary care. You know what they say? Housing, food, education, income, childcare. Over and over and over again. Rebecca Bowen started Health Weeks. She's now part of the Health Initiative. They did a study in North Carolina looking at red and blue political divides. Could not be farther apart in terms of how health care as a system looks. In terms of health, complete overlap. Those 5 things across political lines we can all agree on. So then, how do we mobilize that power to make changes on health? So with that, Luis is actually going to tell you what we've done.
So my name is Luis Manriquez. So I guess the way I came to this work, before I get into the history of it, was so I was an activist in New York. I was doing a lot of work with popular education, and I saw going to medical school as trade school. Right? I'm going to go learn these skills, and I can apply them to developing a practice of medicine. Medicine is a practice of social justice, but that's not the world I saw of healthcare. I saw, how are we going to make these tools the practice of social justice? I actually started out wanting to be a trauma surgeon, these specific tools, and through medical school came to see that family medicine was where a lot of this came. So that idea, how do we connect community organizations and healthcare and patients together, that seems to me to be where lots of conferences get. Right? Here's the list of good ideas. We want to see people make that happen. And so when we were trying to figure out how are we going to create programs that are actually going to address that question of power, we had to think about, well, where have we seen that before? Who's doing this type of thing? And Mark Twain once said, history doesn't repeat itself, but it rhymes. And looking back at our history, at the very beginning of community health centers, organizing was an essential point of addressing what they then called the poverty cycle, what we would call social determinants of health. So on your left, Jack Geiger, who I hopefully know, so Jack Geiger founded the first community health centers in 1964 under the War on Poverty. But to his right is John Hatch. And John Hatch, they were very clear about how this worked. So John Hatch went into the Mississippi Delta ahead of the creation of the clinics and organized 10 community health associations. And those community health associations decided what are the issues that are most important to us. And healthcare was none of them on the top 10. And then they came in with the clinic and they said, we are going to use this access point of healthcare to address all of these, to address the poverty cycle, to address the needs of the community, whether it's roofs on houses or latrines or access to food, etc. Right? So from the very beginning, they're very clear about this. You can get from the Office of Economic Opportunity, you can get the original proposal submitted, and they call it community health action, and it was clearly healthcare as a way into the door that's supported by a community organization. And I had the opportunity to talk to Jack Geiger at the first Beyond Flexinger conference, and then the third one when he was getting recognized for his Lifetime Achievement Award. And I said, why don't you talk about community organizing more? Like, is that still the most important piece of things? And he said, to us, the most important thing is a trained community organizer. So the organizing of the original community health centers, I think, was largely responsible for its successes, but has, over the time, political pressures, the Reagan sort of focus and the funding of community health centers focusing on the delivery of care services, has stripped some of that capacity out of those original community health centers. So we had to think to ourselves, who is still carrying on that power in that community organizing? And when I say community organizing, I mean one thing very simple. And what I mean is bringing people together to develop the power to act on their shared interests. That's what community organizing is. Okay. So the Industrial Areas Foundation is a network of community organizers that has existed since the 1930s, started by Saul Alinsky, continued to this day. We work with the IAF Northwest. And so what we found was a partner in how are we going to take this community organizing approach, bring people together to act on their shared needs, and apply it in a healthcare setting. So we created this collaboration between OHSU and the IA Northwest. In Portland, our local affiliate is Metropolitan Alliance for the Common Good. So those alliances are institutions of institutions, a bunch of member organizations from faith, labor, nonprofits that come together. They decide what are our collective ambitions, what do we want to see happen for the common good, and how do we make that happen. So the Living Wage campaign, the idea of the living wages largely started out of some of the IA work here, or in Baltimore. So how did that work for Healer, our health equity and leadership effort, bringing this community organizing approach into healthcare? So starting with listening, how are we identifying our shared social pressures? But how are we doing that? So what we were doing were listening sessions and one-to-one. So one-to-one relational meetings that are not clinical meetings, but talking to patients about what are the social issues that are affecting you most? What are the things that are keeping you up at night, or the things you want to see your children have that maybe you didn't? So trying to identify shared social pressures. Then trying to engage people doing the community building to cultivate trust, belonging, and a sense of purpose. So how are we taking a bunch of isolated individuals? You know, if you've ever read Bowling Alone, you can talk about the sort of deconstruction of American civic engagement. So how are we trying to bring people back together to have a shared collective interest and to feel that they're not alone? So we created core teams, the Healer core teams, so both amongst patients and staff. So I think for many people, the problem is first a belief that you don't have any ability to act, or that you're powerless against larger forces, or how are we ever going to get started? And that's why doesn't everyone care as much as we do, or as they do? And so we first need to kind of combat that by bringing people together into groups that are able to act together. Then developing the capacity, providing the skills so that people can actually bring those passions and desires into action, into concrete action. So in partnership with MACG, we're using the universals of community organizing and the fundamental approaches to organizing they've developed over the last 8 years and trying to apply them within our context. And those things are all for the purpose of action. So we're not talking about defeating homelessness as a concept. We're talking about a specific need, specific people who can give us the thing that we want. How are we going to get it from them so that we make concrete action on a specific issue? So we take a problem which is depressing, overwhelming, seems like it can't be addressed, like homelessness or affordable housing, and try to cut it into an issue which is something that's specific, actionable, and winnable. And that's where the community organizing comes in and coalition building with community partners. So to give you a concrete example, so through our listening, we did 150 one-to-one meetings, we held 4 listening sessions, and affordable housing was identified as the chief issue. This is in Portland, Oregon, probably similar to here because every large city seems to have the same problem. There is just not enough affordable housing. So as you all may know, community health centers are supposed to have a defined service area. Richmond Clinic's defined service area is 82nd Street, or 92nd Street, west to the river in Portland. And as you go east from the river, the numbers go up and you go further and further into the numbers. And most of our patients, Richmond Clinic is on Cesar Chavez, which was 39th previously. So most of our patients are right in the middle of that area. Most of our patients, however, live up out in the 140s, the 180s, the 200s, because they've been pushed out, right? The old house that was on the edge of our parking lot got demolished and put in some nice condos. The cheapest one-bedroom condo for sale in that unit was more expensive than the house in which I lived as a resident. So affordable housing was our biggest issue. So we engaged about 40 patients to attend HEAL core team meetings and to bring people together so that they were starting to see that this wasn't a specific problem for individuals. And then we had about 20 patients and staff complete some of the organizer trainings with MACG. And so then lastly, we developed with the Metropolitan Alliance for Common Good because they were doing their own listening, and what they found as well was the biggest issue was affordable housing. Right? What they found was that across the churches, across the unions, affordable housing was their biggest pressure as well. So we started talking to who are the people within the housing sector, who are the people in the advocacy world, what are the ways in which we can cut this issue into something we can act on. And we developed a campaign for tax increment financing with the Portland Housing Authority.
Who did the one-to-one meeting?
Trained leaders, ourselves, people from the Alliance for Common Good. So we're serious when we say that we are bringing people together to act on their own self-interest. Who organizes? The people who care about the issues, right? So that's patients, that's staff, that's front office staff. It's all of us. Another example, really quickly, Senate Bill 698. So I'll get to the outcomes of those efforts. So our core team and Healer identified that one of the issues, largely women of color, identified one of the problems patients were having was that they weren't getting their prescriptions in a language they could read. So they didn't know what medicine they needed, right? So if we say, what is once in Spanish, ONCE, once, 11. So if I want to really take my medicine and be a good patient, and look at the bottle, it's supposed to take 11. Not maybe the best thing. So what we found was that it's actually not that difficult for pharmacy systems to provide interpreted languages on the pill bottle. It just costs a small amount of money actually for each pharmacy to upgrade their capacity to do that. So we developed a coalition with several community organizations, culturally specific organizations, to create a bill, Senate Bill 698, to mandate that all pharmacies provide their prescriptions in 14 languages, the 14 most common languages. And through working with those coalitions and lobbying across the state, we were able to move that bill forward. So our impacts, we think about it on 3 levels. So our communities and our health systems, our institutions, and individually. $67 million for affordable housing came out of the tax increment financing effort. So we had patients and we had staff going to city council saying housing is a health issue, along with other people from Metropolitan Alliance for Common Good. The city council voted to increase funding for affordable housing by $67 million. We also worked on inclusionary zoning, safe sleep guidelines, and a relocation ordinance. And we won mandatory translation on red levels for 14 languages. A similar bill in Washington at the same time did not pass. We were able to get it done. We developed internally at Richmond Clinic the ability to be accountable to community for health equity and meaningful community partnerships and a relational culture within our clinics. So if we look at housing before this work, the way we addressed housing was one-on-one. Let's get you on the list for affordable housing. Let's get you on the list tonight for emergency housing. The emergency housing list is 82 months long, and the affordable housing list is 1 to 2 years, depending on when we get you on the list. And then we'll do it again, and we'll do it again, and we'll do it again, because no one who's going to move to the health center can really afford to live in the city. And then lastly, on an individual level, the program prescribed me a purpose. So that is one of our patient leaders who was homeless, got housed through the VA program, came, got his mental health issues addressed at Richmond Clinic, got passionate around addressing housing, and then led on the team to help address these issues. And then lastly, patient and staff leaders advancing, addressing these issues as part of their professional identity. So I'll say one other thing here. So residents were involved in all of this. We have training programs that are included in the residency around community organizing, how to use this as a tool for addressing social determinants. And I remember the residents hosted one of our city councilors at Richmond Clinic to get them to agree to meet with us once they were elected around housing, and they did. And afterwards, there were some people from the churches, and what they were most struck by was, I can't believe these doctors care about us, that they're out here trying to address these issues. Now, I know and you know that all of the doctors care about this, but it's a different thing to show up to address housing outside of our clinical practice. So next steps, We're developing our HEAL team. We're hiring a health equity organizer. So all of this is done essentially with volunteer effort. Hiring a health equity organizer, project manager, and evaluation funding. We're overhauling our leadership curriculum into a health equity leadership academy. We're working on evaluating and publishing our impacts, and we have our staff core team launching a health equity committee for the entire Richmond organization. So, you know, at Richmond, they've known for a long time that first we need to be a good patient-centered medical home and handle our insight game. But second, we need to figure out how we're going to engage the community and do those things. And so now we're developing a health equity committee to lead and pioneer that effort so that we're managing both of these things. Lastly, I'll say this is part of a regional effort. So in Missoula, Montana, we've just hired 4 community organizers working in various service organizations that are trying to build this network. We're working on it in Spokane as well. We have a sponsoring committee that's trying to put together, raise the funds to hire these community organizers and place them within health centers and other social service organizations. We're trying to develop our regional evaluation model and intersecting with health professional education. So we actually have student training organizations in the Health Equity Circle, which now has 9 chapters across the West, as well as residency training